Welcome to Riverside Talk. My name is Denise Mananis. I'm the Associate Vice President of External Affairs for St. John's Riverside Hospital, and it is my pleasure to speak today with Dr. Gary Tannenbaum about vascular surgery and the various conditions he addresses as part of this specialty. But before we begin, I would like to acknowledge my team. We have Candace Cousins-Hopkins, Nancy Anabi, Jason Latore, and Olivia Hunter, who without their hard work, these programs could not be produced and made available to our public. And I would also like to acknowledge our original partners in our community education, the Yonkers Neighborhood Naturally Occurring Retirement Community, the Yonkers Public Library. Those are our original partners, and our new partners, the Ashland Irish Community and Cultural Center, the Department of Veteran Services City of Yonkers, Ardsley Senior Center, the Bronxville Community Center, the City of Yonkers, Community Baptist Church, Greenberg Parks and Rec, Hastings Community Center, Irvington Community Center, Westchester Jewish Community Services, and Yonkers Pathways to Success. So thanks to all of them for helping us get our programs out to the community. We really appreciate you. Now, I would like to introduce Dr. Tannenbaum today. Dr. Tannenbaum has been a member of the staff of St. John's Riverside Hospital since 1992, which is a personal moment for me as well, because you were probably the first doctor that I met when I came to St. John's. And has now, we're so thrilled that he has joined the St. John's Medical Group as the Director of Vascular Surgery and also of the Wound Healing Center. Dr. Tannenbaum began his practice at St. John's after completing training in general surgery at the Presbyterian Hospital of New York and vascular surgery at the New England Deaconess Hospital in Boston. He served as Director of Wound Care and Vascular Surgery for many years at St. John's and was Chief of Surgery before joining the faculty of Columbia University's Department of Surgery in 2015. For the past 9 years, he has served as the Director of Vascular Surgery at New York Presbyterian Westchester Hospital in Bronxville. A graduate of Dartmouth College and Columbia University College of Physicians and Surgeons, Dr. Tannenbaum brings over 30 years of experience in the treatment of vascular diseases to the St. John's community. So with that, thank you for being with us today.
My pleasure, Denise. Thank you.
So I know this is going to be a very funny kind of a question to ask you on the outset, but as a vascular surgeon, you focus on a few different things. But what exactly does a vascular surgeon do? It's not like you're a dermatologist or you're, somebody who's a general surgeon. So explain this to me.
Well, in the simplest terms, a vascular surgeon takes care of blood vessels.
Okay.
So we're involved in surgery and also in medical treatment of various conditions that affect arteries and veins throughout the body.
Right.
Although we tend to stay away from the brain and the heart, because there are specialists, obviously, that deal with those issues exclusively.
So a vascular surgeon, deals with the veins and the arteries. And what kind of interventions are you doing in surgery?
Well, so in terms of arteries, mainly I'm dealing with problems where the arteries are becoming narrowed or blocked, or becoming enlarged and forming aneurysms.
All right, so the blockages, is that carotid artery disease?
So blockages affect arteries throughout the body.
Okay.
The most common sites are in the neck, the carotid arteries, which obviously causes restriction of blood to the brain and can be a major cause of stroke or mini stroke.
Okay.
Other arteries that are typically affected would be the arteries to the lower extremities, which can lead to symptoms like pain when you walk, intermittent claudication, and in more severe cases can lead to blockages that cause problems with wounds or gangrene.
Okay, so the intermittent, what was that?
Intermittent claudication.
All right, so what is that?
Intermittent claudication is the term for a condition where you get pain when you walk a certain distance.
Oh.
It's intermittent, meaning that it happens only when you walk. At other times or with short distances, you don't get symptoms. Typically, people will feel it after walking a couple of blocks when their legs feel heavy or develop actual cramping pain in the calves.
Oh.
We try to separate that from other conditions that can cause leg pain, mainly nerve problems, spinal problems. So we check arterial circulation with special ultrasound tests.
Okay.
And measurements of pressures in the legs, and in that way we can then see if it appears to be a circulation problem and then take it, from there to the next step of further evaluation and treatment.
So circulation problem would be if there's a blockage and the blood cannot easily pass through.
Correct.
All right. So you do the ultrasounds. You're talking about the femoral artery, which supplies
the arteries in the...
and the carotid.
Correct.
Okay. So what are the interventions you can do? Somebody comes back, they have an occlusion, they're definitely got some blockages going on. So what's the next step?
Well, the answer to that question really depends on the patient. So
Okay.
we don't treat tests. A lot of times I'll get patients referred in who've had a scan done that says they have a 60% blockage in the neck, or they have a blockage in the leg artery. And I ask the patient, are you having any symptoms? And they say no. And I say, go home. Because we don't treat tests, we treat patients. And so it really depends on what the symptoms are. So in general, depending on the part of the body, but in general, we treat medically first. So if someone has pain when they walk a certain distance, we'll prescribe them or recommend them an exercise program, because we know that exercise is the best initial treatment for intermittent claudication.
Okay.
We might try medication, because there are medications that can also help alleviate the symptoms.
Let me interrupt that. So exercise can actually, let's push this mic a little closer to you. Yeah. So exercise can actually reduce the occlusion?
No. What exercise does is, so my analogy is always somebody who wants to run a marathon doesn't run 26 miles the first day.
Right.
So people who are getting pain when they walk 2 blocks, I'll ask them to go out and walk regularly 30, 40 minutes, and even if they have to stop 4 or 5 times, to complete that. And what they're doing over time then would be to train their muscles to manage better with the amount of circulation that they have. And the other thing that's been shown to happen is other blood vessels will now start to enlarge and carry the blood where the blocked artery can't.
Oh, that's fascinating. Okay, the body's pretty cool.
Yeah.
Are there lifestyle choices that people make other than the fact that they were maybe not exercising that way that can help not only deal with the blockages that exist, but that maybe can reverse some of that?
Of course.
Okay.
Well, obviously the one that comes first to mind is smoking.
Oh.
Smokers are obviously at a very high risk to develop plaque or atherosclerotic disease throughout their body. And smoking takes oxygen out of the bloodstream. It causes blood vessels to go into spasm.
Oh.
So again, along with exercise, the number one treatment for lower extremity circulation problems is to stop smoking.
Okay.
And certainly I have many patients who have successfully stopped and exercised, and they need no intervention, no surgical procedures in order for them to resume a more normal lifestyle.
Interesting. Okay. So what else other than smoking? Are there medications that kind of interfere or cause problems or help the situation?
So we do have medications that we will prescribe to people to help them walk further. The main one is called cilostazol, and it's a pill that you take twice a day, and over time it helps the blood again to circulate. Doesn't unblock the arteries, but it helps the blood to circulate through the secondary arteries that are still carrying blood down to the leg.
So I'm fascinated because I didn't realize that you could have this kind of an occlusion and be okay and not have pain and be able to start exercising and deal with it in a way that your body could then accommodate and as you said before, sort of adjust itself to having more circulation in other ways. But how do you know, I'm Joe patient, how do you know when it's time to do something else?
So that's again a patient-driven decision. So I'll often discuss with my patients, explain what the situation is based on the tests that we've done, that there may be a blockage in the circulation in the artery in the leg, causing decreased circulation to their lower leg and calf, things that they can try to do, and then find out when they come back for follow-up if they're feeling better, and if not, my next question is, how much is this affecting your life?
Okay.
not being able to walk 2 blocks may not be a problem for someone who sits around the house all day, but clearly if it's a younger person who's working or someone who wants to go out and play with their grandkids and take a walk or play a round of golf, it could be a major problem. So again, we tailor the treatment and the level of treatment to the patient.
Okay. So is it possible that you can have occlusions in your legs, low in your legs versus, like the carotid artery and not have, because to me, if you have a real occlusion in the carotid artery, couldn't that cause a stroke?
Well, sure. One of the risks of carotid artery narrowing is an increased risk of stroke. That being said, most patients who have blockages or narrowings of the arteries in the neck and also in the leg don't have any symptoms.
Oh.
If somebody's not trying to walk 4 or 5 blocks, they may not know that they're having a circulation problem in their leg. Only about half of all strokes are preceded by a symptom, what we might call a mini stroke.
Okay.
So that means that more than half of patients who have strokes never have a warning sign. That's why that's one area where screening and testing of patients who are felt to be at higher risk is helpful.
All right, so that's very interesting, and I think there's a lot of sort of relief for people who are listening to this that, if you go to the doctor and you hear you have an occlusion, it's not the end of the world. That for a lot of them, patient decision-driven, lifestyle-driven, they'll be okay. I think there's a lot of fear in going to the doctor and trying to figure out what the next steps are. So with that said, you don't have symptoms. How do you know when it gets to a point where you actually have to do something?
Well, again, if you don't have symptoms, then it can be difficult to know that. In terms of the arteries in the neck, we know that patients who have a narrowing of greater than 80%, meaning only 20% of the normal amount of blood is passing through, are at much higher risk of having a stroke or a mini stroke.
Okay.
That being said, probably only 1 out of 20 patients with that degree of narrowing will ever have a problem. That means that 19 out of 20 might not, but unfortunately we don't have a test that points which one out of those 20 is at the real risk.
So who is ordering those tests?
So usually the primary care doctor or the cardiologist might be the first to order the ultrasound test to look at the arteries in the neck. There are certain physical findings on exam that might point to a problem, but again, generally history of atherosclerosis elsewhere in the body, like coronary artery disease or lower extremity artery disease, is a risk factor. High cholesterol, smoking, diabetes, all of the things that we normally would associate with a risk of peripheral vascular disease.
Okay. So, all right. So now, you mentioned the word aneurysm before. So where does that come into play? That's not an occlusion.
No. So aneurysm, again, is a term that means that an artery, or in some cases a vein, has become enlarged from its normal size. So the most common site that I deal with is in the abdominal aorta.
Okay.
So the aorta is the main blood vessel that starts in the heart, goes down, gives blood to all the organs, and then splits to go to the legs. So between the branches that go to the kidneys and where the aorta splits to go to the legs is a site that can not infrequently become aneurysmal or dilated.
How does one find that aneurysm?
So again, in the old days, people didn't find it, and lots of people, unfortunately, died from ruptured aneurysms. And think of quite a few famous people that had that problem. Nowadays, aneurysms are typically picked up when people are having tests for other reasons.
Okay.
So if somebody might have a kidney stone, they may have an ultrasound, and a good ultrasound tech will pick that up. Gallbladder stones, x-rays for other reasons. But we still find people, who have significant aneurysms who've never had a symptom and never had a test to show
It's
it.
very silent. That doesn't make me feel good. So what's the difference between all this? So my stepfather at one point in his life had a AAA done, and it was a traditional, open, old-fashioned, so it was 35 years ago or something. So test, so we don't test for it particularly, but it is found.
Right. Now there is screening tests that are available.
Okay.
Medicare will cover an ultrasound of the abdominal aorta, typically in men at 65 years old, and women with a history of smoking.
Okay.
'Cause they
So lifestyle does impact the vessel and its ability to expand. Like, why does that occur in the first place?
Well, nobody knows for sure why an artery might become narrowed from plaque and smoking, per se, versus dilated. There may be some genetic factors.
Oh, that's interesting.
But typically, it's kind of a one or the other. Certainly patients who get aneurysms at younger ages are more likely to have a genetic cause.
Huh.
There are certain, collagen vascular diseases that lead to aneurysms at a young age, but those are fairly uncommon.
So if you are 52 male and who had smoked and have an aneurysm, an abdominal aneurysm, is it possible that it's genetic and that your kids should be watching for that?
So it's certainly possible. Again, 52 is on the younger side to have an aneurysm. Again, I tell patients, I just had somebody in my office today, the father has an aneurysm, the son was with him, and he's turning 60, and I told him in a couple of years you should get an ultrasound. Because there is certainly an increased risk. It's not super high, you shouldn't go running for it, but it's there.
Okay, so you have an aneurysm. So in the old days, it was a heavy-duty surgery. What is it now?
So most aneurysms nowadays are repaired with what's called a stent graft. So as opposed to the old days, which isn't that long ago, since we've been doing that surgery here at St. John's for 30 years, instead of making a big incision in the abdomen or the flank to go in and basically replace the aorta with a artificial graft, we now are able to go in to both groins, into the arteries through needles, so there's no incisions.
Wow.
And thread up through the aneurysm, what's called a stent graft, which is basically a metal stent that opens up inside the aneurysm and it's covered with fabric. And that locks in place, and then blood flows through that stent graft and not into the damaged portion of the aorta.
So you're not actually taking out that damaged portion and sewing it up and doing
Correct.
all these. So is that what the old surgery was, sort of go in and then?
So the old surgery, yes, the
Yeah.
old surgery would be to go in, open the aorta where the
Remove
aneurysm
it?
is, and we didn't remove it,
But
but
you
we
sewed it
sew
up.
a new artificial blood vessel inside, usually
Wow.
made out of Dacron or Teflon, and then actually use the big enlarged aorta to close over that to protect it from getting stuck to other things.
So now this stent that you're putting in, this is done in the OR?
It can be done in the OR, it can be done in the angio suite or the cardiac cath lab.
So do you do that here in our interventional radiology suite or not those?
Well, we do them in the operating room mainly.
Yeah, okay.
Because that's where we've been doing them. They can be done in the interventional suite, but
Okay.
it requires having anesthesia there and so
Yeah,
on. So right
yeah.
now we're doing them.
So
the
in those
operating
ways, it's still a traditional procedure. You're still,
room. Well,
Anesthesia.
regardless of the way you do it, it's
Yes.
it's a
Okay.
traditional procedure.
okay. So that's really cool. So you put the stent in and it's, so now all the blood bypasses and so the pressure is removed from that area.
Correct.
Okay. How long does that stent last?
In general, they last for many years. I mean, they've been doing stent grafts for over 20 years.
Wow.
Certainly the ones that are 20 years old are not as good as the ones we use now. We do have to monitor patients once we do the surgery every 6 months with ultrasound just to check that there's no problems that develop.
Right.
About 10 to 15% of people might require a secondary procedure to fix a problem that arises. It's very unusual to have to go back and do real open surgery, but occasionally that's necessary. But the procedure takes between 2 and 3 hours,
Okay.
and most patients go home the next day.
Wow. And because it's not that traditional open surgery, their recovery time is,
Short.
well, that's great. But it does depend on your sort of your health going into it too.
Well, of course, but again, because it can be done under local anesthesia,
Right.
patients are up and around very quickly. hopefully the risks of the procedure
Are
are
minimal.
much less than the risks of a major open operation.
Yeah.
But again, the trade-off is with the old-fashioned surgery, the traditional open surgery, typically problems from that surgery, will not develop years later, whereas with the stent grafts, we always have to be vigilant and be checking for any issues that might come up, which we can then treat.
So what does that mean about vigilance? That's an annual visit? That's an annual ultrasound? Check it out?
Typically, we recommend the patients have an ultrasound every 6 months
Okay.
to check the size of the aneurysm. So typically, when we put the stent in, we expect that the aneurysm will stop enlarging and hopefully shrink.
Right.
And we also look for any signs that there might still be some blood flowing in the sac of the aneurysm, which could be coming from normal branches of the aorta, which are still open.
Okay.
We also checking the blood flow down the legs, to make sure that the stents that are going into the legs are open and working normally.
Interesting. All right. So veins. You were talking about the vascular system in the legs and the lack of circulation a little bit earlier. So I know that you are the medical director of wound healing here at St. John's. In fact, you were the gentleman who opened our wound healing.
I was one of the first
Yes,
doctors.
you were one of the first doctors when we opened. So talk to me a little bit about those patients and what they're dealing with and why they're coming in. I know there's a large percentage of diabetic patients who have circulatory issues, but who else are you seeing? What's going on there?
Right. So in the wound center, we see a large population of patients who have wounds related to problems with their veins in their legs, as well as the diabetics and other reasons, but certainly diabetes and venous disease are the two main categories.
So just to stop you, what's the difference between the venous disease and the arterial?
So patients who get wounds from arterial disease, it's due to lack of blood flow,
Okay.
typically. Patients who get wounds due to venous disease is due to chronic swelling in the legs and the effects of poor drainage of blood from the legs due to problems due to blockage of veins or veins that don't work normally because of problems with valves in the veins.
So how does that occur? Like problems with valves in the veins? Is that all lifestyle impact on?
No, generally not. So patients who develop venous disease typically would have a history perhaps of a blood clot in their leg years before. So when a major vein in the leg clots, initially you get swelling because the blood has trouble getting out of the leg. Over time, the vein will partially reopen, but the normal valves in the vein, which are supposed to keep the blood moving up the leg towards the heart, become damaged and they no longer work. So now, instead of blood moving up the vein, blood moves up and down, depending on your position.
Oh, so that's the swelling?
So blood kind of collects in the veins, causes the veins to swell, causes the legs to swell.
Are those varicose veins?
Varicose veins can occur due to valve problems in veins under the skin. Typically, that doesn't cause severe swelling. Swelling is more, when it's due to veins, is more due to veins deep inside the leg.
Okay. All right. I got that. So tell me what you're doing for your patients in wound healing.
So when patients present with a wound, first of all, we evaluate them to determine what the cause is. And if it is a venous problem, we will treat them with compression dressings to basically reduce the swelling in the legs, improve the blood flow up the legs by compressing the dilated veins, and that also allows the wounds to start healing. We debride wounds regularly, remove infected or devitalized tissue, and we have special wound care dressings that we use now to help stimulate the healing of the tissues in the wound bed.
So I know we have a very high heal rate in wound healing and have always had it's a great service. So you come in, you have a wound, you get healed. How do you reverse that disease? Yeah, are there things to do that you can reverse the disease?
Of course. Well, again, unfortunately, venous disease, especially the wound type that causes wounds, is a chronic problem. So we can't replace the veins, we can't fix them to a certain extent, but we help to guide our patients in proper management of their problem. So typically that involves elevating their legs, especially at night, using compression garments like stockings during the day to prevent the swelling. We will refer certain patients for special pumps that they can use, again, to help reduce the swelling in the legs.
Okay, so that helps prevent any other wounds from coming. But if you were a motivated patient to heal, other than the wounds, how do you reverse? Can you reverse the disease once it gets to a place where you're actually seeing wounds?
Well, if you keep the swelling under control and keep
Yeah.
that excess blood out of the leg, then the tissues will heal.
Okay.
But unfortunately, it's generally something that you have to do every day for the rest of your life.
All right. Tell me what peripheral artery disease is. I hear a lot about that. What is that something
So,
that you're
again,
dealing with?
PAD is kind of the catchphrase for what we've
Been talking
discussed.
about.
Yeah,
Okay.
with blockage of the arteries in the periphery, in the arms and the legs,
Okay.
and so on.
What are the signs of that when you are 55 and you start seeing changes in your vessels in your legs? Is that something that you can notice and say to your doctor, what is this and why is this? And
Right. So again, so in general, the symptoms of peripheral artery disease would depend on the severity, but the usual initial symptom is the intermittent claudication that we discussed earlier.
right.
So somebody who notices, gee, I
That
go
hurt.
out and take my evening walk with my partner, and now instead of going, a mile, I get 2 or 3 blocks and my leg hurts. I have to stop and rest until the pain goes away. And that's usually the first earliest sign. If that progresses, then you might get pain without walking.
Right.
Typically, if your leg is up in bed at night, you might wake up in the middle of the night with pain. You have to stand up or sit up or hang your leg over the side of the bed to relieve the pain. The final risk is you start to develop sores, typically on the toes or the
Okay.
heel. And the last would be the actual gangrene, where tissue is dying off in the toes, and
Wow.
you have that problem.
Okay.
So that's the usual sequence of events. Unfortunately, some patients, especially those with severe diabetes who have nerve damage from diabetes, may not feel the pain that another patient would. And they can often present with ulcers or gangrene
And didn't feel it.
didn't know they had the problem.
Wow, that's really interesting. So we talked about sort of some lifestyle things and then some other things like compression stockings, and we talked about surgery. Are there pharmaceutical interventions that are sort of in the pathway of helping these patients manage all of this?
Well, again, symptom-wise, we discussed the medication you can use for patients who have claudication.
Right.
There are no medications that will remove or reduce the plaque buildup in the arteries. Certainly watching the cholesterol and taking statin medications is recommended for all our patients with atherosclerotic disease.
Right.
And hopefully it prevents the progression of the disease. But other than that, there really aren't any other approved treatments for plaque buildup in arteries.
Okay. All right. So the other thing I wanted to talk about, you're doing a new procedure, DVT.
Okay.
Tell me about that. I was at a dinner with you, and I know you were speaking to a group of physicians and other providers about this procedure, but I'm really interested to know a little bit more.
So people can develop blood clots in the veins in their legs.
Yeah.
It can come for no reason, but typically people who are sitting for long periods of time or maybe laid up in bed with an injury or surgery can develop blood clots in the veins in the legs and the pelvis. When that happens, it causes severe swelling, can cause severe pain if it's a major clot. So for patients who are really in the most severe group, we now have the means to try to go in and actually physically remove the clots from the veins and reduce the swelling, and also hopefully reduce the risk of them developing problems in the future from the chronic clot.
And that's a minimally invasive procedure as well. So it's called a clot buster. What is it called?
Clot retriever.
A clot retriever. So it's retrieving the clot right out of the vein.
Right.
Okay, that's very interesting. And so you go in kind of the same way you would do the stent placement.
Right. So yeah, we place a needle in the vein and take pictures with contrast under X-ray to see where the clots are. And then we can use this special catheter device that opens up inside the vein, and as we retrieve it, pull it out through the through the vein, we can remove the clot, and after a couple of passes of the catheter, remove most of the clot in the vein, and then see if there are any other problems that might require intervention with stents or other procedures.
So that's really fascinating how technology has come along. But for those patients following a procedure like that or a presentation of a clot, they would go on blood thinners.
Yes.
Okay, so that's it's manageable,
Yes.
right? Have you seen over the time you've been in practice, like progressively things have gotten better and better for the patients? I mean, my shtick always is going to be, go to the doctor, go to your primary, go to your cardiologist, and know that the things that we can do for you are much less invasive and much more manageable than they used to be, for sure. But have you seen?
Well, of course. I mean, when I went into practice years ago, pretty much everything that we did was done with open surgery.
Right.
So surgery on the neck for carotid artery disease has now been at least partially replaced with placement of stents in the arteries. The aneurysms we talked about, lower extremity bypass operations, which was the mainstay of therapy for people with severe arterial disease, is now not done commonly because we have the means to use balloons and stents on the blocked arteries in many cases. So most of what I learned to do in training has now been replaced by other procedures, which luckily I've been able to learn and perfect over the past 30 years. So it's been an ever-evolving and changing practice, which makes it obviously interesting for me and better for patients. Because again, they don't have to have the major operations, that I was taught to do as a young surgeon.
Yeah. It's so fascinating to see it and to see, where you started and where you are now. Any other new things coming that we should know about, or are we pretty good?
Well, I mentioned we are going to be commencing a service to treat carotid artery disease with stents.
Okay.
Stenting of the carotid arteries has been around for many years. Unfortunately, when typically done the way most stents are done through an artery access in the groin, it does carry a relatively high risk of complications, namely stroke.
Oh.
But with this newer procedure, instead of going from the groin, we actually access the artery through the neck.
Oh,
and
so it's almost less of a travel.
Right. Avoid putting wires and catheters past the heart and past the big arteries leading up to the neck. And that procedure is called a TCAR, or transcarotid artery revascularization. And with that procedure, we can resolve the narrowing with a stent with the lowest rate of stroke, heart attack, or death, and when compared to surgery or stents from the femoral artery.
So when you go in through the groin in the what was commonly being done, that had the risk of creating a stroke?
Right, because to get to the artery in the neck, you have to go.
That's a long way to go.
It's a long way to go, but also as you get up near the heart and the other arteries leading to the head and neck, you could break off a plaque or cause a clot that would then go up and cause a stroke. So that held back carotid artery stenting for many years. With the new procedure, through a small incision above the collarbone, we access the artery directly and also have the added benefit of then being able to drain blood out of the artery and return it through a catheter in the vein in the groin after filtering out any particles that might have otherwise gone up to the brain. And that's what makes this procedure so much safer. So it has the benefit of a low risk of stroke and heart attack and the added benefit of a minimally invasive procedure.
That's amazing. When are we starting that?
Hopefully within the next couple of weeks.
Yay. Okay.
Would you like to be our first patient?
No, thank you. Although I should probably get checked and just make sure that I don't qualify. But thank you so much for being with us today, and to my audience as well. Thank you for joining us for another Riverside Talk, and we will see you again. Thank you.
Thank you.